Please commence. Thanks.
Thank you very much, Chairman, and good afternoon to you and the other panel members. On behalf of my colleagues here with me today, Chairman, and the wider Belfast Trust, like the Minister, CMO and CNO before us, we very much welcome the opportunity to come here today to discuss what, for us, is a very important issue. I'm very conscious, Chairman, that we are the first care providing organisation to appear before you. So I think it's essential, therefore, for me at the outset to articulate for you the complexity of emergency medicine and the very challenging environment in which our staff work on a daily basis. Our emergency department staff deal with a huge range of people with very different clinical and emotional needs, from those who come to our departments with a very minor injury, right through to those who require life-saving resuscitation. Patients often present in distress, pain, or with heightened levels of anxiety, which can be manifested with a variety of emotions. Staff care for patients and their families with compassion and empathy at times when they are at their most vulnerable, very often in an environment which is highly pressurised, noisy and extremely busy. It's in this context, therefore, Chairman, and against a backdrop of the Belfast's 2 EDs seeing over 120,000 patients every year, that our staff strive to deliver a consistently high level of safe care to each and every person. Very recently, Chairman, I have spent some time in the Royal Victoria Hospital's emergency department, work shadowing doctors and nurses. The department has been very busy and it has been very challenging for staff. I have seen, Chairman, at first hand, patients waiting on beds in our ED for lengthy periods while waiting for admission to the right specialty, albeit that these patients are being safely looked after in the interim in our emergency department. I have been very struck and very humbled by how our staff deliver care within this environment. They are always professional, always calm, always measured and controlled, and never wanting to do anything that would make an individual patient's experience any less than the standard they would expect for themselves. Equally, I have been heartened by our patients who have been very vocal in their support of the staff looking after them, the work they do and the challenges the staff face. This is borne out, Chairman, by the number of compliments and thank you letters I receive in praise of the emergency department staff and the care that the patients receive there. In fact, it is telling for me that in spite of all our well-publicised difficulties in Belfast in delivering timely emergency department care, we receive many more compliments than complaints from patients. Now, Chairman, I fully understand that care is not just about leading edge or safe and effective treatment. It is about the complete patient experience and how in particular we attend to patients' privacy and dignity needs. It is also about respect and empathy, about living out our professional standards and about seeing each patient as a unique human being with individual needs. But above all, in my book, care is recognising the person as someone in need. The Belfast Trust, Chairman, is established upon 5 core values which our staff hold dear and which permeates all we do as an organisation. Our values and behaviours clearly outline what is expected of an employee of the Trust, especially to treat everyone with respect and dignity, to be open and transparent, to be leading edge, to maximise their learning and development, and to be accountable for ourselves and our services. These values resonate with all our staff because they are reflective of a care providing organisation, and they chime with those staff whose professional codes of conduct include such values. Like all who work in health and social care, we strive to adhere to standards that will improve the experiences of our patients and clients. Respect, privacy and dignity are the 3 cornerstones of this, and they permeate all aspects of our work. Chairman, I do not this afternoon intend to shy away from the difficulties we face in delivering safe, high quality and timely emergency care. You and your panel members will be aware of well-publicised cases from our emergency department where we know we have let patients and their families down, where we recognise that our communication has been poor and at times not as open as it could have been, and where our capacity, despite our best efforts, to afford individuals the privacy and dignity we would expect for ourselves has been lacking. These very powerful stories, Chairman, help us to hold a mirror up to ourselves. They do not reflect the organisation we strive to be, nor do they represent the commitment and expertise of our staff. And while I am pleased they are not representative of the experience of the 120,000 odd people who use our emergency departments each year, I accept them as fact. And I am leading an organisation that is doing all it can to rectify the conditions and circumstances that brought them about. And I hope, Chairman, in some of our answers to be able to elaborate on that. In addition to all we do and have done to improve the way in which we deliver emergency care in a dignified manner, the Belfast Trust is also measured against a number of other quality indicators, which should reassure the public that our hospitals operate within a safe health and social care system. For example, the number of times a person is readmitted as an emergency can provide an indicator of the quality of care. The Belfast Trust's readmission rates, Chairman, are lower than our peer hospitals across Great Britain. Last year, the Belfast Trust was the top performing Northern Ireland Trust in terms of preventing MRSA infections and one of the best for preventing C. diff infections, and we are on track to continue with that trend. The proportion of inpatients who die in hospital, or the mortality rate as it is described, is a very powerful and useful indicator of the quality of care we provide, and we compare our mortality rates with similar UK hospitals. In 2012-13, the Belfast Trust, Chairman, had 5% fewer deaths than were expected when risk-adjusted analysis is used, and 6% fewer deaths against similar acute teaching hospitals in Great Britain. In other words, we are better than many of our peer teaching hospitals at ensuring better survival rates for our patients. In our critical care department, our outcomes for patients are among the very best in the United Kingdom. In conclusion, Chairman, I very much welcome the opportunity to discuss the human rights aspects of emergency care. Where we fail or have failed, I hope to demonstrate through our answers how we have learned. Equally, I hope we are able to explore the significant challenges our staff face, what we are doing to combat them, and where we cannot change them, how we are working very hard to mitigate any impact on our patients, clients, and their carers. Thank you, Chairman.
Thank you. Again, I will start the questions, and I think my first question is really, what did you see as the main lessons to be learned from the RQIA report? And how is the emergency department service different now in the trust from where it was when the RQIA did its original inspection in January?
If I could just lead out on that, Chairman, in terms of the lessons learned from the RQIA inspection report going back to last January, there were some very harsh but telling lessons for us as an organisation about how we look after our staff. And we have certainly learned those lessons. And I'm going to ask colleagues now to articulate some of the ways in which we have done this. How is it different now, Chairman? We will be launching tomorrow a major improvement project in the Belfast Trust around our emergency departments and unscheduled care. What we have done this time, Chairman, is come up with what I believe to be a compelling vision that all our clinicians and staff can coalesce around. We are very much in the business of improving the outcomes for patients, their experience, and improving patient safety. So we're very clear about this vision. We have set up what I believe to be a very coherent and cohesive project with all the right vertical integration and horizontal integration. But more important to me than any of that, Chairman, is the fact that we can only bring about the change required in Belfast as a collective clinical and managerial community. And so we have moved to put many of our leading doctors and nurses in positions now where they can design the required change and work together with managerial colleagues to drive that through so that we can, as I said earlier on, improve safety, patient experience, and outcomes. And at this point, Chairman, with your indulgence, I was going to turn to our medical director to maybe articulate that a wee bit more for us.
Just to give you some detail on the direction of travel that the Trust is now undertaking, we are working on a project regarding improving patient experience and accessing care through teamwork, otherwise known as impact. We have 7 work streams that mirror those described by Dr. Michael McBride, but each of these work streams are medically led, clinically collaborative, and managerially supported. So, similar to the regional task force, we have the work streams of finance, HR, IT, human resources, all underpinning the work streams work and furnishing them with the tools that they need. We have adopted the IHI methodology for improvement. Each of our work streams has an associated Scottish Patient Safety Fellow that will work with the improvement and alongside the team, skilling them up. And every Friday afternoon, we are coming together to ensure the horizontal integration, because patients don't present to one specialty with one symptom. Patients are people with issues and complex fears and anxieties, and they move through the system, whether that's emergency care, respiratory, diagnostics, and our whole system needs to be working together to get it right. So the piece of work that we have embarked on clearly is underpinned by the Berwick principles. Now you'll be aware of Mid Staffordshire, you'll know the Francis report, then the Keogh report, and following on the Berwick report that the Prime Minister asked in the UK. But he wrote a letter to each of the clinicians working in the NHS where he said there are 4 things that we have to do. And the simplicity is empowering. Firstly, safety and quality above all else. Secondly, always listen to your patients and their carers. Thirdly, be absolutely open and honest and transparent in all that we do. And fourthly, invest in our staff and embrace the culture of lifelong learning. Those are the principles that underpin our improvement piece as one of the teams working under the umbrella of the CMO or CNO's task force. That is our direction of travel. We are very clear. Thank you.
I wonder how you measure the actual impact of that, and if you could tell us a little bit about how you will decide whether that initiative is successful or otherwise, and what are the measures? And
there are a number of measures, both quantitative and qualitative, but we must not forget the qualitative, because they're sometimes more important than actually hitting the numbers. And for that reason, we are setting up a user and carer reference group. So we'll base our information on our experience on the 10,000 voices. We'll be influenced by what the Human Rights Commission finds, but we are shaping our future plans on what our users and carers feel. So every single work stream will have to present their plans to a user and carer group and have them tested, critiqued, and improved in that partnership model.
And in terms of if that original blueprint changes once it's gone through the user and carer group, will people outside who have an interest in this be able to sort of track how that works in practice?
Absolutely, because we're going to be open and honest in all that we do and completely transparent. And remember, improvement work is a journey. It is never a destination. So we're always going to have to improve. So when we talk about a regional task force for the next 6 months or a year, that's not the destination. The destination is to always improve. Healthcare is always evolving. There are new treatments coming along every day, every week. The CMO talked about the new NICE drugs. We have TAVIs, we have PCI, the emergency blockbusting treatment for heart disease, the blockbusting treatment for strokes. Everything evolves. We cannot stand still. And so this is how we would like to embrace all our improvements all the time. And it's very clear to me that every single member of staff have 2 jobs to do. The job we do today and the job about improving tomorrow.
Can I ask, and whoever wishes to answer this, question I asked earlier, I think, of the Minister, which is, in terms of delivering care in A&E, what do you see as the main resource and non-resource challenges that face you? What are the key issues that you have to grapple with?
In terms of resources, Chairman?
Both resources and non-resources, so start with resources and then look at non-resources.
Certainly in terms of resources, we have to make sure that we have the right number of suitably trained staff in our emergency departments, and we have a very clear path for identifying that. In terms of non-resources, we are very conscious that we need to manage the flow of patients throughout our hospital much better. That is a non-resource issue. That is a managerial issue. That is about making the hard yards inch by inch and managerial grunt, so we get patients to flow much better. That is why the project that the Medical Director has just outlined is so important, because the doctors and nurses working alongside us will be redesigning things so that we have a better chance of patients flowing more effectively through the system, so that patients don't have to wait in our emergency departments any longer than is absolutely necessary before they make their way to the right specialty and the right bed. In a wider context, a system-wide context in terms of resources, it's very clear, and I think the Chief Nursing Officer touched on this, that we need to start moving towards through 7-day-a-week working. That will require additional resource because many of our services are set up on a 9 to 5, Monday to Friday basis. And if we are to have through 7-day-a-week working, there will be a big investment required in terms of additional staffing and additional capacity. But that is a journey we definitely have to embark on because all of that will play a very key part, in my view, in improving the experience people get in our emergency departments and in particular at weekends. I don't know whether colleagues want to add to that.
I think as part of that, we've already agreed an annualised job plan for our consultants within the Royal Victoria Hospital. We have expanded the consultant numbers. We have expanded the nursing numbers because obviously for staff to do the job they wish to do, they need to have sufficient numbers to do it. But we have further work around our middle grades. We have further work around the environment that we're working in, the temporary building, and how we move into our permanent residents in the new build, and obviously how we cover our 2 emergency departments to a similar level, because they are both level 1 EDs.
And certainly in relation to nurse staffing and the changes in nursing roles, the Chief Nursing Officer mentioned the change in the complexity of the patients we see coming to our emergency departments now, and certainly the role of the nurse today is very different compared to the role of the nurse even 2 or 3 years ago. However, the fundamentals of good nursing practice remain the same around compassionate, dignified care and respect. And certainly I would endorse her view that at the moment nurses are the only people who are there 24 hours a day, and we need to ensure those nurses are in the right place at the right time. Some of the RQIA recommendations, which you'll be aware of, allude to that. And at the time of the report, we were on a journey in relation to changing our staffing levels in respect of that. It did give us further impetus, and it's a great credit to firstly the staff who are there, that they remained with us through a very, very difficult time, and secondly, that we were inundated with applicants to come and work with us, in spite of our very negative publicity around that very difficult time. It's also very important for me as the Director of Nursing, who's responsible for the care and dignity of patients, that nurses value that aspect of care as well as the more technical aspects of care, and that we have enough people on the ground to deliver both levels of care. And certainly that's something we review on a daily basis. It's very important that people do have private dignified care, and that is an absolute challenge when a department is very, very busy, and certainly when it's very congested. And it was very difficult for me personally, as well as all of my colleagues and executive team, that our staff felt they couldn't raise those concerns or felt they weren't being heard, because certainly those concerns were being raised, and that we weren't able to affect change as quickly as we might have wanted to. But certainly the words I hear the team using now are optimistic, it feels better. It's still very, very busy, and there are times when the unit is very, very congested. We also have our unit in the Mater as well, which has different pressures, serving a different client group. So it's something that evolves all of the time that we need to be very mindful of.
I suppose for me, Chairman, just to add that, I think for me, certainly the overall lesson learned was that we need to keep our staff engaged at all time and keep our staff with us, and that the communication needs to be very, very good, and that our staff need to feel they're being listened to, need to feel that they're being adequately supported. And I think we've now embarked on our journey so that our staff will always feel that that is the case in the future.
One final question, and then I'll pass it to my colleague Marion, and that is, how confident are you with this change process and what you're doing, that you will avoid a similar problem when winter pressures hit over the next few months?
Rather than use my own voice, Chairman, I'd prefer to do this. And this morning we had a trust board, and what was heard loud and clear in our boardroom this morning was the voice of ED through one of the emergency department consultants, and what was very clearly heard was the voice of wards through other senior doctors. And what they described for the trust board this morning, their optimism that things would be better this winter, because they are now up front and centre, working alongside us, helping to redesign this. That's not to say it won't be once again very challenging, that there won't be difficult times ahead, but we have a greater degree of optimism than at any time before, because I think we have complete re-engagement again now with our clinical colleagues and the clinical community, and we will be moving forward together as a collective now with a view to improving this for our patients and clients. And of course, allied to that will be the managerial effort, making sure our planning is much more sharper than ever before, and our preparation is sharper than ever before. Because as the Chief Medical Officer said this afternoon and others, we have a growing elderly population. The demand keeps growing, the people keep coming through the doors, so we need to put ourselves in a position to be able to rise to that challenge, Chairman.
Thank you.
I have 3 questions, one on participation, one on serious adverse incidents, and one on staffing. If I start with the participation question, what processes has the Belfast Trust in place to ensure that feedback from patients and staff is used to monitor the quality of care provided to them in the emergency department? And could you give an example of how feedback has made a change to the way the service has been delivered?
Thank you, Marion. I'm going to turn to Brenda to answer that.
The Chief Nursing Officer this morning referred to, or this afternoon I should say, referred to the patient and client experience standards and the 10,000 voices work. We've been working very closely with our colleagues in the PHA, firstly around the monitoring of the patient-client experience standards, and there is specific work done in relation to the emergency departments and acute medical units. We actually received a very good overarching report last year, where the majority of the survey observing practice, speaking to staff and speaking most importantly to patients, was largely in respect of respect, attitude, behaviour and communication, all in the high 90s and up to 100%. There were 2 areas where we did fall short, and that was around interruptions in care, and I feel that's where there is a busy department, and secondly in relation to explaining why that interruption was happening. On the back of that information, we put in place an action plan with the frontline staff, led by the sisters in the department, where they reviewed all of the elements of those standards. In relation to the 10,000 voices work, which is a newer piece of work, you will be aware one of the impetus for the RQIA inspection was a very difficult story which our staff placed on that process, and we took a number of actions in relation to that, which we have spoken about already. Secondly, in relation to the other stories, we are working through a process with the staff on the ground. Within my team in nursing, there is a senior nurse who's leading that, who coincidentally is also from an emergency department background. He was one of the deputy charge nurses in the department, so he has a very good relationship with the team, and that is being led and that is monitored on an ongoing basis. But also for me, very importantly, we listen to what our patients say to us on a daily basis. We look at complaints, we look at compliments, and whilst the majority of our feedback is very good, that doesn't take away from the impact of a poor experience on an individual, and it's certainly not what I would wish for my mother or father. So we have to have the balance in how we deal with that as well. In the ED, it is a huge staff. There are over 100 nurses, and there are a large number of junior doctors at all grades. So to get that information across, it is a very, very, very complex process, and we need to make sure our communication of all of that learning is very consistent as well. And that again is led by the team on the ground and also supported by the managers, with regular team meetings, with safety briefings, with what we call in the department the safety round, which happens twice a day, and that's led by the senior doctor and the senior nurse. And I think one of the big lessons for us, and you referred to this earlier about the recommendations of why meetings didn't happen, I think that was symptomatic of where the department were, because it would have been my expectation that did happen, and that was a great shock to all of us. So that this is multifaceted in how we manage this, and we hear, what our patients say, both good and not good, and how we deal with that, and that we're very honest and that we meet with families regularly. I think it's quite interesting. All of us are in the department very regularly, and even when the department is very crowded and the place is very congested, largely patients are very complimentary about the care they're receiving. But we have to be mindful that's not enough, because it is very difficult to give personalised, individualised care when you're on a trolley in a public area. And it's something we need to manage very sensitively.
I suppose by way of example, in some of the work that we had done from feedback, and we had got some feedback in from patients in relation to how individuals were communicated with and what they appreciated and what they didn't appreciate. So we had embarked on a customer care training that involved that some of the users of the service actually participated in and gave some of their honest feedback, and so all of us that actually took part in that training heard it from the users of the service direct, and then able to impact and bring that back to day-to-day practice.
Can I turn to staffing? I'm just wondering, does the Trust have any concerns about the use of locum staff of all specialities in emergency departments, resulting in the difficulties in recruiting and retaining such staff? And what have you tried to do to address any difficulty you may have with recruitment and retention in ED?
That's fine, Cathy. Brenda will pick up on that.
Okay. From the medical point of view, we do struggle to adequately staff our department. We have increased the number of consultants in partnership with the board, and we continue on an active recruitment campaign, because the College of Emergency Medicine did advocate additional consultants. We continually run difficulties in our middle grades and recruiting of that. Now, that is not a unique issue for the Belfast Trust, and indeed it's not a unique issue for Northern Ireland as a system-wide healthcare service. It is actually across the United Kingdom and even within Europe, the emergency departments struggle to get adequate staff and retain them. Now, clearly, we've been working with our partnerships in the board. We've had a campaign of overseas recruitment as far as Cuba in the past, and we continue to look at innovative ways of recruiting staff, such as looking at roles that have other elements, such as education or trauma fellows, to try and make these posts attractive. But you must appreciate that working in a very pressurised department with huge numbers of very sick patients coming through is difficult. So we do need to continue to recruit and retain, and that was one of the things why we went down an annualised job plan, which clearly said we recognise this is intense, we want to work, we need to deliver 7-day working, and we need to have an extended day working. So, Monday to Friday, our consultants are there until 1 a.m. in the morning. So our level of cover is good for the Royal ED department. It is not the same in the matter, because when we've analysed our workload, many more Category 1 or 2 patients, many more ambulances do come to the Royal, because it's a regional trauma centre. Now, we do need to work around equity across the service, because they are both level 1s, and that is a process of looking at how we merge the two to have a single service and have staff working across the units. We are looking at innovative ways of attracting individuals, and we are looking at suggested models where we allow people to have different roles, such as simulation training, developing safety portfolios, educational portfolios. So in the sessions that they do work in A&E, and they're very pressurised in the emergency department, they have other time when they can regroup, catch their breath, become refreshed and go back. Because it is not good for anyone to work in a situation that you describe with nurses maybe going 12 hours without time for a drink of water.
And then in relation to nursing, as I said earlier, we've had very successful recruitment for nurses in Belfast, both in the Mater and in the Royal. The one issue we have is really not recruitment, it's how we retain and support those staff. We have our gender profile is largely female, young women who choose to have families, as is their right. But obviously that's something we have to manage in our workforce planning. Similarly, in respect of our induction and our support, after the RQIA inspection, we put in place additional arrangements around a bespoke induction and support for those new staff coming in. That with it brought other pressures to the staff who'd been there over the difficult winter, who were then required, whilst the department was still very busy, to support those nurses coming through. And you'll be aware there's a regulatory requirement for nurses who are newly qualified to have a very stringent mentoring process, again, which is very time consuming in a busy department. We also have support meetings, and I have to say the ED team now have a very robust process of monthly meetings with staff nurses, and they have the opportunity to talk to a number of level of staff within the department, also at director level and within senior colleagues in nursing. In relation to different types of nurses, the Chief Nursing Officer referred to the guidance in relation to developing advanced nursing practice. I chaired that work for the region, and it's a piece of work we're very proud of because it will set a policy context for advanced nursing practice going forward. However, it's quite costly to educate an advanced nurse practitioner, and we do need our medical colleagues to provide the supervision and training, which is very difficult when they're already stretched in other areas. So that's a piece of work we're doing, although I have to say our medical colleagues are very supportive of the approach, and we have 2 advanced nurse practitioners in training already in the Royal. In relation to emergency nurse practitioners, we do recognise that they offer a very good service for the minor injuries stream, but we need more people to deliver that service throughout more hours of the day, and we're working with our colleagues in the Health and Social Care Board to look at how that could be resourced going forward, because our resource at the moment wouldn't be large enough to offer that over a longer period of time. I do think it's important I also talk about AHP staffing, because I'm the director responsible for AHPs. And whilst we have AHPs in the department, again, that goes back to the 7-day working and the availability of other times of the day. And where they offer a service, particularly in relation to rapid access to physiotherapy and occupational therapy, that has proven very successful. And finally, in relation to support staff, that also falls under my remit. And certainly to have adequate cleaning, catering support, security support and portering support, again, we have increased those levels, but as the service becomes much busier, that's something we need to keep under constant review. And my colleagues in the department, led by the nurse consultant, who's also Associate Director of Nursing with us, and I know you're hearing from her tomorrow, she is very heavily involved in the work that the Chief Nursing Officer referred to around the workforce going forward. Because what is right for today will not be right for next year, and we have to have a model that considers all of the issues I raised with you and advancing the practice of nurses.
You asked about the serious adverse incidents, and I was going to turn to the medical director. Is that okay?
I have one question on that. It's in terms of, could you outline any improvements that the Trust would wish to make to the serious adverse incident reporting process, given your experience of operating it to date?
Okay. First of all, I would like to acknowledge the Dr. Michael McBride's comments around serious adverse incidents. The vast majority of care that is delivered within the Belfast Trust is of a very high standard, but healthcare is complex, and on occasion things do go wrong, and sometimes that has devastating consequences. But that is very difficult for all those involved, not just the patients and the families, but also for the staff. And so when you ask me my recommendations, and I limit it to two, the first is I'd like to build on the good work that has been going on in Belfast around the mortality and morbidity meetings, and the ensuring that learning is cascaded in a timely manner with the development of the significant event audits and what we term as debriefs, hot debriefs to the clinical teams involved, so that key issues are learned quickly and implemented. But we could build on those so that we actually have a patient safety system running throughout our organisation. And the second thing, which I actually think is most important, is that we need to develop a system that cares for those involved at this difficult time. And that's not just patients and carers, but also our staff involved. And some of the work around Schwartz rounds, where you talk about the human factors of how it felt, I would be keen to explore and support within the organisation.
Thank you.
Thank you.
Passing on to Paul, who will complete the questions for this session.
Thank you very much for your remarks. I appreciate being reminded of the complexity of emergency care. I appreciate being reminded of the wonderful work being done by a huge number of highly dedicated health professionals. And I've just got two questions. One, what two things does the Trust most need that it does not presently have? And be realistic, not world peace, open checkbook, reasonably realistic. Second, and last question or point is this. The United Kingdom has ratified the International Covenant on Economic, Social and Cultural Rights, which includes Article 12 on the right to the highest attainable standard. The United Kingdom has also ratified the UN Convention on the Rights of the Child, which has quite a detailed provision on the right to the highest attainable standard. I could go on, but those international treaties that I've just mentioned are legally binding at the international level in the United Kingdom. They're legally binding at the international level on the United Kingdom government. There is also the European Convention on Human Rights, which has rights related to health. And as you know, there's the Human Rights Act, which has health-related rights. That's enough. Now, these health-related rights are not just vague legal texts. Some years ago they were, but not now. A lot of work has been done in the last 10, 12 years to make these legal provisions operational. We've done a lot of work on how to make them operational, practical, how to implement them, policies, programs, plans, practices, and interventions. Now, don't misunderstand me, we haven't cracked it yet. There's still a huge amount of work to be done to figure out what does a hospital look like that's shaped by human rights. That work is ongoing. But my point is that it's not just vague legal operational stuff any longer. That there are detailed suggestions, recommendations, guidance on how to make human rights real for ordinary people in communities and in districts and in hospitals and elsewhere. Now, it's clear that following the RQI reports, there must have been thousands of meetings, right? And it's clear that there are numerous measures that have been put in place. Fantastic. My question is, have human rights ever been mentioned in those meetings? Have they ever been brought to bear upon those interventions, those measures? And not just human rights, but specifically the right that should be at the heart of the trust, the right to the highest integrity.
Okay. In terms of your first question, what two things do we need? I suspect you might get a slightly different answer from each of us, but certainly for me at this point in time, we need two things. We need to continue to work together as a clinical and managerial community to bring about the change required in our trust. And we've begun that journey. I'm very encouraged by that. The other thing I mentioned earlier for me that will make a real difference over the next few years is if we can move to through 7-day-a-week working. And that'll bring about a huge improvement and a huge improvement in human rights in our health service. Coming back to the question around, in all the numerous meetings and so on, has human rights been mentioned and so on? I do know that there is a lot of work goes on in our organisation around human rights.
Sorry, Mr. Dillon, I'm having trouble hearing you.
There is a huge amount of work goes on in the organisation around human rights, and I was going to ask Bernie, in terms of some of the support and some of the discussions we've had recently around this issue, to articulate that for the panel.
In terms of around the
Bernie, we'll need to move the mic towards you, I think, please.
okay, talking about the rights for staff, the respect and dignity and care for patients, and the rights for staff to be heard, voices to be heard, for them to be supported in what all that we've done. In terms of what we've done and immediately after the whole episode, in terms of when our QIA had reported to us informally, was about putting support clinics in place for staff to come and have their voice heard, to a senior group of staff, including central nursing, from psychology staff, occupational health staff. And part of all of that was, we looked at, again, through with our HR colleagues and our trade unions, about the employee wellness tool, and looking at the assessment of or the wellness of our employees, and putting an action plan in place in relation to that. Again, reiterating in terms of our values within the organisation, which we do believe are in line with those that are valuing the human rights, which is the respect and dignity and the right for communication, and being open and honest and striving to be the best.
With the chairperson's permission, and
Yep.
if you wouldn't mind, can I press you a little bit on that? I know we have to stop for a break. I understand that many of the values of human rights are implicitly there. My question is a different one. Okay? My question is just very brief answers. But have human rights explicitly been part of this process of change? Has anyone ever mentioned the International Covenant on Economic, Social and Cultural Rights, Article 12 on the right to health?
I think we'll have to come back to you in the answer to that.
Thank you very much.
I'm going to indulge myself, which is one of the joys of being the chair. Martin, you said that that others might have different answers to Paul's first question, which is what are the two things that you would like that you don't have? I'd like to ask each of your three colleagues, but very short and succinct answers, what your two things that you would like that you currently don't have. And bearing in mind Paul's rubric of not world peace.
I suppose for me it's about the whole system working better together. So in terms of having more access for primary care for longer in the working day, if that was possible. And then for me on the other side is around what we would refer to as our back door in terms of more for our community infrastructure, so to be able to support patients in their homes for longer, and again support them whenever they are ready and medically fit for discharge and their acute care of episode is over. And it's about getting more of that infrastructure to be able to do that on a timely basis.
Mine is probably a bit more far-reaching, but certainly the adverse publicity and the poor experiences patients have had, which are well documented, have caused a dent in public confidence. And I would like every patient coming to either the Royal ED, the Mater ED, and it would be remiss of me if I didn't mention the Children's Emergency Department, since I'm a children's nurse, that they all are confident in the level of care they will receive. Certainly the staff we have working to deliver that care come out every day to do an excellent job, which they do the vast majority of the time. But I would like that to be the view of everybody who accesses our services in Belfast and the Greater Belfast area. And secondly, in relation to nurse staffing, certainly in our current financial constraints, I would be very keen that we could find some way, whilst being very aware of the difficult times we work in, that the good work we're doing in relation to improving our staffing levels, which will ultimately improve care for patients, and that some way is found to fund that in the coming year.
And for me, I would like a system that works 7 days right across both primary, secondary and back into the community. Because actually some of the pressures you see within our emergency departments is emergency departments never close. And 2/3 of our care is provided to our patients and their carers out of hours. So I want a system that actually works 7 days a week right across both primary, secondary and community. And secondly, I want a system that our staff feel safe and supported and enabled to learn without the fear of being publicly pilloried. Because actually healthcare is complex. If you look at the number of interactions that go on, and for us to get it right, our staff are our greatest resource, and we need to care for our staff to care for others.
Thank you, Martin. I'd like to thank you and your team for their evidence. As I've said with others, we would be more than willing to accept any written submission that you wish to make. We will obviously follow the work that you're doing over the next few months as our work unfolds. And thank you for coming along today to give evidence before us.
Thank you, Chairman.
Thank you very much.